Hi everyone, please accept warm greetings from me and my other colleagues from Community Pediatric Team at St. Mary's Hospital in Kettering, UK. I'm Dr. Mahdieh Malekpour, one of the community pediatric trainees, and going to present the audit we did in Kettering, which was audit of medical surveillance of the children with Down syndrome, which was done between 2018 and 2019 against DSMIG guidelines. In advance, I would like to express my huge thank you to the other authors, Dr. Bandana Joshi and Dr. Raghavendra Gangavati, our consultants, and also Dr. Louise Ingram, pediatric trainee, for their endless help and support in this project. As we all know, Down syndrome is one of the commonest chromosomal abnormalities with overall prevalence of 10 in 10,000 live births, and it counts for 8% in Europe in all registered cases of congenital anomalies. Because of improvements in median survival of these children, some guidances have been created, and this has been for giving optimal care to them. So we did an audit of clinical practice in Northamptonshire Healthcare NHS Foundation Trust community pediatricians, in line with the DSMIG guidances and based on the recent literature. We went through 8 main audit components, including cardiac and thyroid diseases, hearing and vision, cervical spine and growth, and sleep and celiac screen. We also obtained some additional information like offer of genetic counseling referrals, prevalence of comorbidities, educational placement for school-age children, review intervals, and acute pediatric input. For the sake of time, I haven't put slides for these items except for the prevalence of comorbidities, which I will go through that later. We identified 54 patients from System 1 medical records using the keyword Down syndrome. 52 children were identified in April 2017, plus 2 new children which were identified in December 2018. So total number came up to 54, and we collected data from January 2018 and December 2018, so about 24 months. We did the data analysis between May 2018 and February 2019, and we did it in children's services at St. Mary's Hospital in Kettering in the UK. The information that we obtained, as I mentioned, was from System 1, which is the electronic record system. The information was obtained from last 2 community pediatric clinic letters and also other System 1 records. We also used the Kettering General Hospital pathology system for obtaining the blood test results. So among these 54 children, 44% were male and 56% were female. And most of them were in primary and secondary school. For DSMIG surveillance guidelines, we went through 5 main areas: cardiac disease, thyroid disorders, hearing, ophthalmic problems, and appropriate monitoring of growth. These standards have been set out to a minimum safe standard for basic medical surveillance, which are considered essential for all children with Down syndrome in the UK and Republic of Ireland. So going through the cardiac component, generally, We know that between 40 to 60% of babies with Down syndrome have congenital heart defects. Of these, 30 to 40% have a complete atrioventricular septal defect. The highlights from the guidelines suggest to identify cardiac problems by 6 weeks of age at the latest, to do the routine referral for the children who have never had an echocardiogram and who have no symptoms or clinical signs and has a normal ECG. However, we have to urgently refer them if they've never had an echocardiogram and who are symptomatic and or have abnormal clinical signs and or ECG. So in our audit, we found that actually we've done pretty well and we did 100% of cardiac assessments. And in 55%, we documented and saw evidence of CVS examinations. Out of this 55%, 22% were done in both appointments and 33% in just one appointment. We found types of cardiac abnormalities, including ASD, which was the commonest one, atrial septal defect. Also other types, including patent foramen oval, PDA, VSD, and AVSD were found. And we also had 3 patients with tetralogy followed and mitral valve leak. Regarding thyroid disorders in Down syndrome, it's reported that these children can have thyroid disorders in 28 to 40% of cases. Diagnosis is usually difficult with just going through the symptoms, so we have to do biochemical screening. Highlights in DSMIG guidelines are all infants should undergo a screening for thyroid disease in the neonatal period, and then all of them should undergo biochemical testing of T4, TSH, and thyroid antibodies at 1 year of age, and then every 2 years throughout life. We did pretty well in this area in our audit, we found. So especially in neonatal screening and also screening at 1 year of age, 100% of the assessments were done, and we did 89% good in the thyroid function assessment for the children older than 2 years of age. We also went through the thyroid abnormalities types. In 33% of the whole sample, they had thyroid abnormalities. We had subclinical hypothyroidism in 6 children, so about 1/3 of children with thyroid abnormalities. One of them was on medication, and the rest 2/3 had either hypo or hypothyroidism, and all of them were on medications. Regarding hearing impairment, we already know that between 50 to 70% of people with Down syndrome may experience impaired hearing at some time during their life. The highlights from DSMIG guidelines are as all children with Down syndrome should have newborn hearing screening, followed by targeted hearing assessments, initially at 6 to 10 months old, and then annually till 5 years of age, and then 2 yearly throughout life. We did very well in this area. So 33% of the whole sample had hearing impairment, and we performed 100% in this area in all age groups of screening. Regarding visual impairment in Down syndrome, we already know by age of 4, 50% of them may experience refractory errors. We also know that there is a 10-fold increase in congenital cataract and infantile glaucoma. Nystagmus can be as common as 10%, and cataract and keratoconus are approximately 4 times more common among these children. DSMIG highlights suggest to do visual behavior assessment by the child's pediatrician prior to formal assessment. All of them should have orthoptist and ophthalmologist assessment between the age of 18 months and 2 years. And if no abnormality at the first review is found, then this assessment should be repeated at 4 years of age. And then after 4 years of age, should happen at least 2 yearly throughout life. We also did quite well in this area, 100% in visual behavior at birth, and in the age ranges between 18 months and 2 years, and doing them at 4 years of age. And we did 90% of them after age of 4. So in our audit also, we found that 81% of the people in our sample had visual impairment, with refractory errors to be the commonest. So 34 among 54 of them had refractory errors. We also saw squint, lazy eyes, nystagmus, cataract, fourth cranial nerve palsy, and congenital nasolacrimal duct obstruction. Regarding cervical spine surveillance, we know that craniovertebral instabilities can be between 10 to 20% among these children. Generally, routine radiological investigations is not recommended. And during our reviews, we have to go through warning signs like neck pain, abnormal head posture, or torticollis. And if any of these warning signs are present, so we have to go through proper clinical history, physical, and neurological examination. Cervical spine surveillance in our audit showed that one child had confirmed atlantoaxial instability and was under a spinal surgeon. And discussion of warning signs happened in 31% of the children, and CNS examination was in 27%. Regarding growth, we had shorter stature. We've got shorter stature, underweight, and overweight, which are common in these children. The suggestion is height and weight to be frequently done in the first 2 years and at least annually throughout childhood and at regular intervals in adult life. Head circumference to be done at birth and 6 weeks of age, and then as clinically indicated to be done regularly. Growth surveillance, in our audit, we did height and weight and documented that in 88% of the cases, and we plotted them correctly on the Down syndrome charts in 65%. We documented underweight, overweight in 29%, BMI was plotted in 50%, and dietetic referral happened in 71%. Regarding sleep surveillance, obstructive sleep apnea is quite common in children with Down syndrome between 50 and 100%. Almost 60% have abnormal sleep studies by 4 years of age. There is no clear consensus currently in the UK regarding doing pulse oximetry and how to interpret them. But the recommendation is from DSMIG is to do them at 6 months of age and then annually between 3 to 5 years of age. We had, in our audit, we had 70% documented sleep history. Regarding celiac disease, prevalence is between 1 and 19%. Routine screening is usually controversial, but recommendation in DSMIG is to do HLA typing for DQT and DQ8 and do the tissue transglutaminase and total IgA based on the results from the HLA typing. In Kettering, we do them with tissue transglutaminase and total IgA, which was done in 63%, and in 35% it wasn't done. And only one person, we didn't have known situation because the person had been transferred from another area. Just going through quickly through the comorbidities, we documented some comorbidities in our audit, including ADHD, ASD, tic disorders, diabetes mellitus, juvenile rheumatoid arthritis, epilepsy, hemiplegia, portal vein anomalies, partial cerebellar hypertrophy, syndactyly, scoliosis, leukopenia, total alopecia, and malignancy, including Wilms tumor. So conclusion and summary of our audit was several Down syndrome specific morbidities can happen. Screening programs are available, including DSMIG. Although the most frequently occurring comorbidities we mentioned have been considered, but there is still a wider range which need to be considered in all these children. Now these children have a better life expectancy, and the focus should be in long-term morbidities and improve their quality of life. In our audits, we did good in many areas, including vision, hearing across all ages. All had CVS cardiovascular examination assessment prior to appointment. That means echocardiograms, and all correspondences were copied to relevant professionals. We could do better in thyroid function tests and thyroid function follow-ups in children with more than 2 years of age. And we need to work on requesting thyroid antibodies, doing cardiovascular examination, growth parameters, and plotting them on Down syndrome charts, cervical spine monitoring, sleep history, celiac screening, and follow-up in children between 0 and 2 years of age. And our recommendations were in a few areas, including routine celiac screening, to do them based on the DSMIG guidelines like HLA typing, to do sleep studies and get the history at around 3 to 4 years of age, which we've started doing them. And also further discussion about interpretation of routine pulse oximetry and to be done by whom. We would also like to arrange meetings with our orthopedic team and to do dental assessments annually, and offer of genetic counseling between 0 to 6 months, and follow up 6 monthly in less than 2 years of age, and annual follow-up in more than 2 years of age. These were our references, and I'm now ready to hear about the questions. Thanks for listening to to our presentation. Thank you.